Good morning, everyone. Good morning and welcome. Delighted to have you all here at the first Connecticut Health Council event for 2015. We're particularly delighted to have Linda Rosenberg here, who will be formally introduced to help kick off, I think, will be a very informative and interesting panel discussion on this very important topic. I am sorry to break up all the networking. I went past numerous conversations, heated debates as to whether Sunday's game will be played with inflated or deflated balls, which raises all kinds of anatomical questions that I'm sure we prefer to discuss, but we're here for mental health this morning. So thank you all very much for being here. I want to thank the Marriott downtown here in Hartford for being our host, and certainly want to thank Intercommunity Health, who's our sponsor, our corporate sponsor this morning, and I'll be introducing Kim Beauregard shortly for remarks, who in turn will introduce Linda. I want to thank the Hartford Current and Fox 61 for their continued media sponsorships of Connecticut Health Council programs. Just also want to call your attention to the fact that our annual celebration will be held on March 23rd over at the Bushnell, and you'll be getting more information on that, but it'll be an opportunity to celebrate the successes of many things in the Alliance, but certainly to celebrate the accomplishments of the Health Council last year. Up on the screen and in your program, you have a list of our current founding partners. Many of you are in the room today. We want to thank you for your continued support and engagement. It's invaluable. Any of you who think there are other organizations that would have an interest in being a founding partner can certainly see Amy Cunningham, who will be up here at the end of the program, or Nancy Wheeler, or me, or any of us who work at the Alliance. We'd be delighted to expand this group and be ever more effective and championing the reputation of Connecticut, the brand of Connecticut, as a center of health excellence, and that is what the Connecticut Health Council is all about. Just before I introduce Kim Beauregard, I just want to make sure that you will hear, our founding partners will hear from us probably in the mid-February with a questionnaire asking you to evaluate the past couple of years of the Health Council, to solicit your suggestions about things that we ought to be doing in the future. Is all part of our 4-year investor engagement and strategic planning process. So more to come on that. This initiative, the Connecticut Health Council, came out of the 4-year planning process that we did back in 2011. So the effort does bear fruit, and we appreciate those of you who take the time to respond to the questionnaire. We'll be holding focus groups, particularly a vertical one on the Health Council. So more to come on that, and again, look for your continued improvement. As I turn this over and introduce Kim Beauregard, who will in turn introduce Linda, and we'll get her remarks and presentation, and then the panel discussion, just want to indicate something as an illustration of how you as founding partners help our thinking. The mental health topic was one that was introduced for discussion about 2 years ago. We looked at different ways we might approach it. In your program, there's a list of the group of people who've worked with Amy and others on this. She'll be recognizing them at the end of the program. But it's as a result of that group that we are here today, the group that put us in touch with Linda and really helped shape this initiative. One of the things that will come out of it is, subject to further discussion, is the idea of having some smaller focus groups on specific topics, subtopics within this broad topic of mental health, all with the idea of getting people more connected, understanding what the strengths and assets of this region are in this particular topic. We all believe that Connecticut can play a leadership role in what has become a more visible part of the whole healthcare healthcare topic. So we thank you for your participation and look forward to that as we go forward. The other thing I was going to mention is what we'll do is comparable, those of you who are with us in 2012 and 13, to a series of workshops that we did on the Affordable Care Act. So it'll look something like that, and Amy will be communicating, and that group will be communicating more information. In addition to Linda, we'll all be introduced, but I do want to thank our 4 panelists who are here this morning, who will participate after Linda's remarks. Deputy Commissioner Annalisa Dowling from the Connecticut Insurance Department, Commissioner Pat Reamer from the Connecticut Department of Mental Health and Addiction Services, Brian Keyes, who is the president of the Connecticut Psychiatric Society, and Arnie Menschel, a partner over at Halloran & Sage. We thank all of you for joining us here this morning. So without further ado, let me introduce Kim Beauregard, who has been president and CEO of Intercommunity Health for the past 11 years. Intercommunity is a community health organization that's provided primary care, mental health, and addiction services to individuals, families, and communities in Connecticut for over 35 years. Kim has more than 27 years of experience delivering behavioral health services in direct care and administration. She's a licensed clinical social worker and has spent most of her career working with adults with persistent and prolonged mental illness and substance abuse disorders. She holds a master's degree in social work, a master's degree in psychology, and one in urban studies, as well as an honorary doctorate of human letters from Charter Oak State College. It's been a pleasure to work with Kim. She has provided tremendous leadership and energy and substantive direction on this whole topic of mental health. Certainly under her leadership, Intercommunity has expanded to include children's services and primary care services, and we're delighted to have Intercommunity as a founding partner and Kim as one of our leaders on this very important topic. Please welcome Kim Beauregard.
Thank you, everyone, so much for being here this morning. Intercommunity, we're very honored to have been able to sponsor this event, and we feel it's a very, very important topic that many of us in this room have talked about for many, many years. However, with the changing environment and healthcare environment, really feel like we need to continue to advocate and strongly to be sure that the behavioral health and addiction services are representative as we move forward in the healthcare world. So I do want to thank Oz and Amy very much. They've been wonderful to work with, and I've been on the council and since the beginning, and one of the founding partners. It's been wonderful to kind of watch from the business world perspective and how healthcare has really started to touch everyone in lots of different ways. So I really do want to thank them. Oz did a great job. Thank you for talking about Intercommunity. So I don't want to repeat any of that. We have historically been a behavioral health organization, but for the past year and a half been providing primary care, primarily because we knew that people with chronic mental illness were dying 25 years earlier than the general population, and knew that was not acceptable. So after quite some strategic planning, decided that we really needed to provide on-site primary care for our folks, and that's been working very, very well. We're waiting to get a designation as a federally qualified health center lookalike. That's very important to us. And we also, over this past year, and have just yesterday signed paperwork where we're affiliating with alcohol and drug recovery centers, which is ADRC in Hartford, which is an addiction services, and that together now will really have Intercommunity have the depth and breadth that we need on a very wide scale, from residential services to crisis services, housing, detox, intensive residential, clinical services. So we're a broad organization serving the community, and we're very excited to be doing that. We know that as things are changing, we really want to continue to work with the bigger players, the hospitals, and I did want to just introduce Chris Dadless, the President and CEO from St. Francis is here. Thank you so much. We know he's committed. Thank you. Has certainly been committed to addiction services with their work with ADRC and their own behavioral health, and we're looking forward to continuing to working with them as for access, for coordination of care services. And of course, we've worked with Hartford Health Care for quite a while with behavioral health services and our crisis services. So today I'm going to introduce Linda. I have a page bio. She said that I cannot read it. She instructed me on that. So she, as you will be able to tell, she is an extremely accomplished woman, a certified social worker, is the president and CEO of the National Council for Behavioral Health, who's also just done a affiliation with other substance abuse organizations, again, really integrating all of those services. But for me, and I think one of the things that you'll see that has me the most excited is I've seen Linda speak and present many, many times, and when I do go to where she's at, it's very empowering. Her enthusiasm, her dedication, her knowledge of the facts and the issues is extremely helpful. And again, when I walk away, I'm really able to, with her voice in the back of my head, able to go out and continue to do the work that we do. We know it's difficult work. I believe it is really about fighting discrimination. I've learned that from our commissioner. I think we can use that word. It really is about fighting discrimination that happens against people with mental health and substance abuse disorders. So we're very grateful everyone's here today. I do actually also want to thank the Intercommunity leadership is here today also with us, and some of our board of directors. So thank you for being here. You're in for a very fun-filled morning. So thank you again. Linda, please.
Thank you so much. What an introduction. Oh my God, I hope I don't disappoint. But before I begin, let me thank the Health Council and particularly the Mental Health Committee for having me here. I'm very excited. I don't think I have been in downtown Hartford before. I was saying that last night, and it is a very attractive city. So I will be back. I also want to thank Oz. I've decided that should he decide to run for office again, I will move to Connecticut and campaign for him. He was a very charming dinner companion, and in fact interviewed Kim and I thought he was a professional radio person. So he is quite skilled. Also Amy Cunningham, who has taken very, very good care of me, and that is only matched by Kim herself, who actually picked me up at the airport. Usually I'm wandering around looking for a cab. I'm not used to all of this TLC, but it's been just lovely. And she, of course, is a member of the National Council, a great organization that is really on the cutting edge, as are many of your Connecticut organizations. And I also want to acknowledge my boss, the head of my board, Jeff Walters, who ran the Reshford Center for years and now is a national consultant on things like integration of mental health, substance use, and primary care. I'm joined by an amazing panel. I can't wait to hear what they have to say, and we'll go over who they are as soon as I'm finished. And I think hopefully you will ask some very provocative questions so that we can have a really honest and open discussion. So without further ado, because I want to leave plenty of time, let me begin. I'm going to be talking obviously about mental health. I've spent the last 40 years in working with people in all kinds of positions, myself, people with serious mental illness, so it's something I am very committed to. And we're going to try to do three things. We're going to talk a little bit about mental health equity and the promise of healthcare reform, specifically the Affordable Care Act. We're going to talk about the state of care for people with serious mental illness, and then what needs to be done. And your panel will be talking about what you're doing right here in Connecticut. But before I begin, I thought what I would do is tell three very brief stories to kind of give you a sense of who we're talking about. You know, mental illness is a very big term, and it encompasses lots of disorders, anxiety, depression, schizophrenia, bipolar. And so today we're really focused on people with the most serious illnesses. And I'm going to tell you the story of three people: Timothy, Gabriel, and Shirley. Timothy, 21, was a young man with serious mental illness. His trouble started in his late teen years, which is very often the time of onset of schizophrenia. He ran around outside without his clothes, thinking he was a knight fighting dragons, and he was in and out of the hospital. After one hospital stay, he was caught shoplifting 2 paintball guns. He grabbed a pocket knife, threatened employees, and then begged a cop to shoot him. He was stunned with a taser and put in jail. In jail, he tried to kill himself 3 times. He pled to resisting arrest and assault and was sentenced to 3 to 5 years in a Michigan prison with 5,000 other inmates. In prison, he took a shower without permission and was put in solitary. When he flooded his cell, he was chained down, hands, feet, and waist for stretches of 12 hours, 16 hours, and 17 hours. All of it was recorded on a 24-hour surveillance camera. The tape recorded his descent. In 4 days, he could barely walk, he had bed sores, and in the shower, he fell over. Timothy was again chained to a concrete slab until he died of dehydration. And only the surveillance camera took notice. He lied there for almost 24 hours before he was discovered. Timothy's story is one that reminds us of how frail our service system for people with serious mental illness is, and how very often people wind up in tragic circumstances. We do, though, have services like the ones you provide here in Connecticut, which have a much happier ending. On a recent Friday night, the police in Campbell, California were called EMQ Children and Family Services. They called them, they're a local community agency. There was a 9-year-old boy, Gabriel, who had a knife to his throat and was threatening suicide. His parents spoke only Spanish and were undocumented. EMQ sent out their crisis team and a psychiatrist saw Gabriel. They developed a safety plan for Gabriel and began to treat the family and Gabriel in the home. Today, Gabriel lives at home, goes to school, and everybody is getting the help that they need. Shirley, 44, spent most of her life in and out of psychiatric hospitals. She spent time, when not in the hospital, in homeless shelters and living on the streets. Last January, multiple community agencies came together and committed to coordinating services for Shirley. They moved her into an apartment. She agreed to her first apartment she has ever had in her life. They connected her with an assertive community treatment team, which meant treatment came to her rather than expecting her to go to treatment. And 1 year later, she's living successfully in George, Utah. So there are happy endings, and I just wanted to tell those stories so we understand who we're referring to this morning in our remarks. In many ways, the stories of Shirley and Gabriel represent the best of times. In 2008, Congress passed a law saying mental illnesses and addictions were to be treated the same as any physical disorder. George Bush signed that law, the parity law, and the Affordable Care Act in 2012 affirmed that by including mental health and addictions in all aspects of the Affordable Care Law. So these are really the best of times, and you're going to have your insurance commissioner talk a little bit about that and the impact, certainly Pat talking about what your state is doing. But they're also very complex times, because in the United States, we decided we were going to tackle two big problems. One is the quality of care, and the other was the cost of care. And so the Affordable Care Act actually had 4 strategies. The first one being insurance reform. Insurance couldn't deny you coverage because you had a chronic illness. You could stay on your parents' insurance till you were 26. The second was coverage expansion through the expansion of Medicaid, which you've done here in Connecticut. About half the states have done that, and also subsidies through the exchanges. And the last two, delivery system and payment reform, is what we're beginning to experience now, and in many ways are the most complex. Atul Gawande is a surgeon and a policy thinker and writer, and I encourage you, he has a new book out called Being Mortal about aging in this country. I encourage you to read it. But what he said is that insurance reform and coverage expansion are really technical fixes. They're relatively easy. They just cost money. But in fact, we've had some success. Over 9 million more Americans have health insurance since the ACA. The uninsured rate has decreased in the country from 20% to 15%, and health spending remains low. It was well over 6%. It's now 3.7% and steady. So we've made a difference already, and no matter who is in charge in Washington, the ACA will not go away. There'll be lots of posturing about it. Congress will probably put a new law on the floor in the coming months, appealing it, but they don't expect that to happen. The same kind of controversy occurred when Social Security was introduced and when Medicare was introduced. It's part of our American way. But you never take something away once you give it to somebody, and we all know that. The service redesign, the purpose of it is to reduce hospital and institutional care. You're in the Northeast, and there was a study a number of years back by Dartmouth that showed that healthcare costs on the 2 coasts were over twice as much as healthcare costs in the middle of the country. Why? Because we have lots of hospital beds. And when you hospitalize people, you spend lots and lots of money. So the point of the service redesign is to reduce hospitalizations, and it's also to integrate care. Kim talked about that in terms of people with serious mental illness, but it's true for all of us. There was a great article in the New Yorker about a year ago comparing 2 counties in Texas and comparing Medicare spending in those counties, and how one county spent more than any other place in America, and the other county spent among the lowest per capita of Medicare spending. And what made the difference is that in the high-cost county, when you went to the doctor, you had a full battery of tests. And everybody you went to gave you the same tests. They got a CAT scan, they were going to use it, and they were going to bill for it. So the point is to both connect services so you no longer have that duplication, and then to identify your high-cost population. And people with serious mental illnesses and chronic addictions are high cost. They often have comorbid physical disorders due to sometimes the medications they take, sometimes lifestyle, and very often poverty. People with serious mental illness wind up going on Social Security income, on Medicaid, are really driven into poverty because its onset is late teens, and so have all of the conditions that go along with being poor. Half the cigarettes in this country are sold to people with addictions and mental illnesses, and we now know what that causes later on in life. Excuse me. So the ACA is a very, very intriguing bill in many ways. Now, I know you've all heard it was 2,000 pages, and of course, what they don't say is almost every bill is that long. Bills are complex, but it really said, we're going to try a whole bunch of stuff to make care better in this country. And in fact, the Centers for Medicare and Medicaid have an Office of Innovation. And when Don Berwick was the head of the Center for Medicare and Medicaid during the implementation, the early implementation of the ACA, he said, we're going to throw everything against the wall and we're going to see what sticks. Now, no one would have believed that a few years ago, that a federal agency would be that really innovative and inventive. And they had, 3 ideas among many, many. One is collaborative care, that all of the people who treat you would talk to each other. The other is the notion of a medical home, which actually comes out of pediatrics, and I know you have your head of your children's hospital here. Actually, the National Council, with the support of our board, lobbied very hard to have health homes in Medicaid, where people with serious mental illnesses could get both mental health treatment, addiction treatment, and physical care, and I know you have instituted health homes here in Connecticut. And the last, and probably the biggest change that is really sweeping our country and is being tremendously pushed by CMS, are something called accountable care organizations. About half of them are big hospital systems, the other half are big group practices. And they're almost becoming like insurance companies. So they're going to own a population, they're going to go at what's called at risk for that population, ultimately getting a payment. We will each have an amount that someone gets paid to take care of us, and if they spend more than that, they're on the hook for it. If they spend less, they actually get to keep some of the savings. And there are some pioneer ACOs in different parts of the country that actually have seen those savings and benefited from them. So payment redesign means all care will be managed. Think back in a way to the 90s and the era of managed care. And there was really a tremendous outcry. People hated that word. So we're not using that word now. We're using collaborative care and ACOs and other language, but it does come down to the same thing, a pot of money that someone's managing for your care to avoid duplication and to improve the quality of your life, all aided and abetted by electronic health records, so people can communicate with each other. The shifting of risk is interesting because right now, most people are paid what's called fee-for-service. You get paid in healthcare for the service you provide. Again, the movement is away from that to either bundle payment, case rates, or really global capitations, where again, a pot of money for your care for the year. And so these organizations are going at what's called at risk. And the result of that is really you need to have deep pockets to be at risk. So we are seeing across the country hospitals consolidate, buy each other, form obviously ACOs, some form insurance companies. And the other interesting thing we're seeing is we're seeing private equity go into healthcare in ways we never saw before. And if you were smart enough to buy some healthcare stocks just a few years ago, you're doing quite well. There is a lot of money in healthcare. Although we're containing costs, the money is moving in different ways, and investment money is really moving in. So we have urgent care, we have retail clinics. I got my flu shot this year in a Walgreens. Last year I got it in Costco. It's what people want, this tremendous convenience. And the other thing we're seeing, because of parity, we're seeing private equity move into private psychiatric hospitals and into residential treatment for addictions. I don't know how all that's going to play out, but it really means that healthcare is part of what we call in this country the monopoly economy. Think about your neighborhood hardware store and Lowe's and Home Depot. Think about airlines. There are only about 4 airlines left in the country. Walmart, 57% of all groceries. And we see that beginning to happen in healthcare. The question is, what happens to the community organizations like KIMS, the community organization that Barry Simon is in the audience and runs, Wheeler Clinic that's also here. And the notion is 2 things would happen for people with serious mental illnesses. Their organizations would actually become part of big hospital systems, deeply embedded, providing behavioral health services, or they would be standalones. They would be like Kim. They would be a health home. They do physical care, mental health care, and addictions, all in one place. And it's a great fantasy, right? It's actually good and often will come true, but it is also a very difficult time. Because at the same time, and I want you to remember back, in the 1800s, state hospitals for people with mental illnesses were the great new thing. They were going to solve all the problems. People would go out to the country, they would have a farm, they would live, beautifully, and everything would be great. Well, when I got out of college, I went to work in a state hospital. And the things I saw, at one point, the psychiatrist on the unit had to medicate me. It was not a beautiful sight. People were marched into bathrooms to be counted at change of shift. People were restrained who disagreed with staff, and both the patients and the parents were really too intimidated to complain. So we knew better, and then we had the financing. Medicaid was developed, and we could begin to develop community services where people could get help like Gabriel and Shirley in the community instead of suffering like Timothy. And that was the stage we've been in, for the last 20, 30 years. It was called deinstitutionalization, but we know it didn't work for everybody. And we have people like Timothy in jails and prisons, people like Shirley who live on the streets. And so there were unintended consequences of a good movement where people would not live in institutions that at best are neglectful and at worst abusive, but instead would live amongst us in the community. Now we're moving to the next, really, I think, big transition, and that is integration, where from the silo of being separate and unequal, both mental health and addictions are part of the bigger healthcare world, and organizations are expected to be part of that world. And so we now need to be very careful because these organizations really are caring for 10 million very fragile, very ill, and costly people who are both socially and clinically vulnerable. They have serious psychiatric illnesses, addictions, physical conditions, but again, as I said, they live in poverty and so have issues of housing and trauma and violence that is perpetrated against them. And so those people have been hidden away for a long time. And probably some of you in this room who are involved in, big hospitals or law firms really didn't give that much thought to these independent agencies that were existing and exist in your community serving these people. But there is much more public awareness now. And people really are telling their story. When I was a little girl and you had cancer, people whispered about it. They did not talk openly about it, and now we all wear pink ribbons. That has begun to happen now with mental illness and addictions. And so it is, again, the best of times because of that. But nevertheless, we still have low penetration in terms of the need. 40% of people who need treatment don't get it. And when you look at addictions, probably 80 to 90% of people who need treatment don't get it. So we still have a lot of work to do, and we still count on those community agencies. And they are dealing with lots of things. So until very recently, in fact, we really knew but didn't think we could do much about the fact that someone who developed serious mental illness wouldn't get the services they really needed until about 7 years into their illness. Because of the way our system is designed, they wound up in emergency rooms or with their primary care physician, and they didn't get known until they were quite disabled. We now know we can intervene at the first psychiatric episode and really make a difference. And I'm sure the panel will be referring to some of those efforts right here in Connecticut. The other thing is that mental illness is still the most common reason for going on Social Security disability. So we have a lot of work to do. And in fact, we have a suicide in this country every 16 minutes. And of the 10 most serious illnesses, 9 of them have been reduced in terms of mortality over the last 10 years. The only thing that continues to go up is the suicide rate in this country. And for people between 15 and 34, suicide is the killer other than unintended accidents. So it is still a very serious issue that we need to pay attention to. And the very organizations that think about this and deal with this have a set of complications. They embrace the idea of integration, but they have really always been managed. Their costs have always been kept under control. And when you look at that chart about healthcare costs and how they were rising for many years, there is an exception to that, and that is care for the most seriously mentally ill and people with addictions. So when we're trying to ratchet down costs, when you're ratcheting down the costs for organizations treating people with serious mental illnesses, you're ratcheting down costs in organizations that don't really have margins. And again, that leaves them in a fragile state and can have people wind up like Timothy did rather than the way Shirley and Gabriel did. The other issue is that those community organizations provide both medical services, psychiatric services, and really social services. And because of the expansion of insurance, many states have really withdrawn their own state money. They say everybody has insurance now. What do you need general fund money? And in Michigan, where I'll be in 2 weeks and where Timothy lived and died, there was actually a crisis around that because they took all the money out of the system, and just now the expansion is taking hold. And so organizations are literally going out of business as a result of that. So they're learning to talk with healthcare, with players, and it's a different language, and with different kind of staff, and that's a stretch, and a skill set people are learning. And they're streamlining operations. One of the things Kim has done brilliantly, and actually Tyler, who's her COO, is helping other organizations, is doing things like same-day access. So if you're part of healthcare, and a primary care doc or surgeon has someone who needs treatment today, they need to be able to send them and they need to be able to get into care. And for these community organizations, that's a shift. So they're moving away from wait lists. It's not 6 weeks to see somebody, but they're really there when people need them today. I think the other thing we're beginning to see is they understand that they have to negotiate rates. That's also a new thing. It used to be a fixed amount of money you got. Now you need a big backroom operation. You've got 80 different insurance companies you're dealing with. Those are very sophisticated challenges. And with their slim margins, they're unable to make the kind of improvements you need to make, including electronic health records and health information technology. You know that we've got to be texting patients now, right? Just like my dentist. Just text me, I have an appointment next Monday. That's the new world. There are monitors in home that will actually do mental status checks with patients, and you'll only have to deploy a real human being if that data doesn't look good. So we have a world of technology that we have to be able to take advantage of, and I hope some of our panelists will talk about that. We certainly are seeing mergers, and every week we have a member organization that's joining a hospital system. And that is a good thing, we hope. And we hope those hospitals, which are undergoing their own just enormous change, including being penalized for readmissions, will be able to embrace and take on the responsibility for people with serious mental illnesses and addictions. And of course, here in Connecticut, your own governor has announced cuts. The cuts this year, I understand, are nothing compared to the plans for next year. And I would urge you, on behalf of people with serious mental illnesses and addictions, to really help him understand that this is not the place or the time to ratchet down. And that really you'd like to have lots of Gabriels and Shirleys and no Timothys here in Connecticut. So thank you, and now I'm going to introduce our panelists. Please join me, our illustrious group. Yes, please come up, absolutely. Now, I hope not everybody's leaving because they've had quite enough of me. Now you're going to get to hear many more interesting people, in fact. I'm going to quickly introduce them again in the order in which they will come up, make remarks, and then I want you all to be thinking of provocative questions, right? Okay, promise? Yes? Okay. So we're first going to hear from your commissioner of the Department of Mental Health and Addiction Services. But Pat Reamer is not only your commissioner, she's actually head of the association of all the commissioners across this country and really a leader amongst them. So we're very excited to have her. Dr. Brian Keyes, the current president of the Connecticut Psychiatric Society, who's a board-certified child, adolescent, and adult psychiatrist, and really on the clinical faculty of the Yale University Child Study Center, one of the best, if not the best, in the country. We also have Ann Melissa Dowling, the Deputy Commissioner of the Connecticut Insurance Department, and what a job that is. All of these new laws are what she is trying to interpret and make sure people live with and actually live both the letter and spirit of the law. And then if they don't, we have our next speaker, Arnie Menschel, who is head of a big law firm here in Connecticut and will litigate all of these issues in the coming years. So without further ado, let's turn this over to Pat.
Thank you, Linda. I just said to Kim, there's nothing worse than speaking after Linda Rosenberg. But I'm going to try and take it down just for a few minutes to Connecticut. So I was frantically writing notes while Linda was speaking about some of the parallel things that are going on nationally and here in Connecticut, and then where we may be ahead and some of the things that I'm concerned about as we move forward. Let me start with the system as it stands right now. So in the public system, the system that is funded by Medicaid, Medicare, and the Department of Mental Health and the Department of Children and Families, because we have a bifurcated system in this state, we serve the adults, about 110,000 individuals annually. That's both for mental health and substance use. So it's a large population, and as Linda so appropriately said, those are only the people that we know about and that we can get to. I spent, I don't know, probably about an hour yesterday on an individual young man. You know, you get a call from a state rep, it's their constituent, they want him in services that day. And we don't want to miss that opportunity, right? When somebody comes forward with an addiction in particular and they say, I want help, the last thing we want to do is say, come back tomorrow, right? So we are seeing more and more people seeking services, and we need to have what Linda talked about, which is same-day access. We're seeing that grow among our providers, and we really believe that's the gold standard. So I want to congratulate all of you that are doing that. It's not easy to do. You really have to have a flexibility and a model that's going to work. I would also say the one thing that I was listening to Linda talk about, which has always scared me. I've been in this field for 30 years, maybe. And the idea of sort of a capitated model where somebody is receiving payment for all the care of an individual, especially with a serious mental health issue or a substance abuse issue. My fear is that organizations will step away from that capitated rate for some of those individuals, because there's a lot of cost involved in that care. It's not inexpensive to have ACT teams. We have ACT teams across this state. We pulled them back probably about 12 years ago. We had stopped funding them as an organization. We stopped providing that level of care in the true form in some of our state-operated mental health agencies as well. Very quickly after Newtown, we got funding to bring ACT teams up across the whole state, so to be able to provide the most intensive services in the community. What we hear from the individuals that we serve in Connecticut is very loud. We have loud advocacy agencies in this state, and I have to tell you that I am very proud of that. I think that those are great organizations. We learn from them. Many of them are run by people in recovery themselves. And those individuals consult with me, tell us what the system should look like, and are starting to move into some service delivery as well. And so those organizations, I think, are also organizations that are at risk because, as Linda said, the margin for a private nonprofit in this state that we fund, I'm just going to use what I know. At the end of the year, if a CEO says to us, we have $150,000 left, can we buy a van? That's what we're talking about. We are not talking about, $1 million endowment and $1 million bottom line. And that's one of the things we have to make sure we educate people about, because there is this notion that there's a need for more care, and there is, but we are in very tight fiscal times. I've just seen a preview of our budget, and it's the starting point, but I can tell you that it's very frightening. That with the implementation of the Affordable Care Act, any provider in this room who knows DMIS and is funded by DMIS knows that we did take back grant dollars last year with the assumption, 2 years ago, with the assumption that everybody would be insured. The one thing we have to remember is that in Massachusetts, right, who implemented this before any of us, the people with behavioral health disorders are the last people to get insurance. So even though I believe Connecticut's down to about 4% uninsured, I'm looking at Ann Melissa, I think that's the latest number. In behavioral health, it's running more at 7-8%. So our providers are still seeing people without insurance. Or on spend downs, right? If you're a Medicaid recipient, after you have a certain amount of money, you have to go on a spend down, that creates problems. Or you are on an exchange product, and what I'm beginning to hear is that the co-pays and the premiums are somewhat cost prohibitive for some of the people that need, again, mental health and substance abuse services. So I think those are things we have to be aware of. The health homes have been rolled out. I think that's the good news. We were very lucky to get those funded in the last budget round, and I think it's the beginning. So we're only funding health homes right now for individuals with serious mental health disorders. We've got to get to substance abuse and substance use agencies to be able to do this. And it's being done in probably about 5 different models. So we have agencies that are providing primary care, sometimes initially funded through a SAMHSA grant, which is the national funder for mental health and substance abuse, who are opening primary care in our local mental health authorities. So those agencies, some of them have grants that have seeded them and they will continue. Some agencies are hiring primary care physicians. I can tell you the one thing that I think we've learned in Connecticut around this so far. There are many lessons to be learned. You can build it and they will not come. So we have individuals who have serious, serious trauma histories. We have individuals who've experienced the extreme discrimination that I believe people experience when they have mental health and substance abuse issues. I wouldn't be doing my job if I didn't say, can we stop calling it stigma? Because that's really not what we're talking about. And when you talk about stigma, everybody goes, ugh, you know, they don't want to hear it. Stigma is really about how the individual feels about themselves. I was with a parent recently whose son had successfully detoxed and been rehabilitated from heroin use. The son killed himself after he got clean. He was so embarrassed about his addiction. That's stigma. That's how you feel about yourself. How other people react to you when they see you, if they think you've got a substance use history or they know it, or you look like you have a mental health issue, that's discrimination. Let's be really clear that we need to, language precedes behavior change. So we need to change our language so that we can change our behavior. I think that's really critical. And the other thing I just want to mention is that a department like ours, Mental Health and Addiction Services, we do provide funding for all sort of the ancillary things that people need, housing, jobs. Those are things that we know help people get into recovery. Our employment rate for our client population with mental health disorders is 8% in this state. 8%. The national is 4%. So we're doing better, but we're not doing well enough. So we have a lot of places to go. It's exciting. It's also frightening, frankly. I worry a lot as we move forward and the budget crisis continues and there's all these expectations on the system and nobody wants another Newtown, right? God knows I don't. But we also are on this edge where anything that happens in the community, there's a loud outcry that the system isn't doing enough, that we're not able to engage those 40% of individuals that are out there not receiving care. And people continue to believe that people with serious mental illness and substance use disorders, but particularly mental illness, as we know in this state, are very dangerous. So we have the law that has us providing voluntary admission data to the state police so that people who go into a hospital voluntarily cannot get a gun for 6 months. I understand why that happened, but think about that. If you're a policeman in this state and you carry a gun, and we know cops have a very high suicide rate, right? You cannot go in for a voluntary admission and keep your job. We really have to think about that. So that's something that I just would encourage you all to think about in terms of the treatment system, discrimination, and the way that we are moving the system forward, and some of the missteps that we can make if we're not very careful. The partnerships are great, the mergers are great, we are seeing more and more of that. I support that wholeheartedly, but I do think that we have to be very careful about the most serious and most vulnerable population that we serve that is not always going to be inexpensive. So with that, I will turn it over.
All right. Well, I'm happy to be here this morning speaking to all of you about this incredibly important topic. I think that this is a time of incredible change in medicine and in mental health treatment, that there's a lot of changes in how things will be paid for, in results that are sought, and how things will be organized. Typically, we as psychiatrists have practiced in the community, often more in private practice, but also some hospital-based practice, clinic-based practices, and in other ways. It's typically been a fee-for-service reimbursement, and that's really not the most efficient way of paying for health care because it can tend to increase testing and assessments and maybe things that aren't always necessary. I think that psychiatrists are interested in working as more of a team. I think there have been barriers to doing that. It's not how it's, I think, taught in training. So there has to be a change with that. And I think it's also not how people are used to operating. They're used to operating in 1 or 2 person offices, seeing their own patients, and not having much contact with anyone outside of that. And I think that's a real problem. I think that stems from privacy laws, from stigma or discrimination, so that we're even more careful about what we do and talk about with patients with mental health or substance use disorders. I think that bringing all that together in with medical treatment, standard medical treatment, may destigmatize or help to destigmatize or reduce discrimination. If people see it more as just a part of regular health care, there's not as big of a concern. When probably about 25% of the people in the U.S. have mental health or substance use disorders in any year, and maybe around half get treatment. Those that do get treatment or get referred for treatment, often they go for only 1 visit and then don't continue beyond that. So our practice of sort of these referrals is clearly not working. The ideas about more integrated care, whether that's co-location or being in the same sort of physical building, or with more embedding where the psychiatrist is part of the actual overall team, I think can be more helpful with that. It's not, at this point in the country, it's not done to a huge degree. They looked at, there was a recent study of ACOs, and I think only about 14% of them had fully embedded mental health care in their ACO. They tended to either contract outside or not contract at all, and just refer people out, or to have some people working within the organization. But the real embedding seems to make a difference. There are multiple models that have been looked at across the country. The ones that seem to be the most effective, and they've looked mostly at depression, substance use disorders, anxiety, and then various medical illnesses like coronary artery disease, diabetes, cholesterol. The ones that seem to be the most effective have a lot of similarities. So they have teams that meet frequently to review the cases. They assess patients that they're concerned about with mental illness with evidence-based tools. They continue to follow those for reassessment with evidence-based tools. They have case managers and care coordinators to work directly with the patients, to give them education, encourage them to take medication, participate in treatment. And they have frequent reviews, including with a psychiatrist, to determine the progress of the patient. When the progress is not being met as they would expect it to, then there's the ability to have full psychiatric consultation or changes in the overall treatment plan. And this seems to provide the most or the clearest benefit. I think it's going to take some work to get there. There are a lot of logistical reasons. One is just the space for people to be in the same offices together. There was a thought, I think, with DCF had an idea this year that we should really try to do more co-location of mental health in pediatrics offices, which sounds like a great idea. However, most pediatricians practice in small offices and they don't even have the physical space. So just this one basic thing can interfere with the whole plan. I think that there's starting to be some funding for case coordination, which is very important as the pediatricians or adult medical treaters like PCPs and family practice are trying to manage some of these mental illnesses. There's some reimbursement for that case management component, which I think is very important, because just to rely on the physicians to do this back and forth, there's not really, I think, much ability to do that. What else? I think that, there is certainly a consolidation into much bigger groups. Initially, like in Connecticut, with more probably Hartford Hospital System, Yale New Haven Hospital System, and a lot of medical practices are being bought by these systems. And there are pluses and minuses to that. It gives you sort of more bargaining power. You have more access to the electronic medical record system and other software that are very difficult to access if you're a solo practitioner in your own office. It's often too much of a financial burden to bear to think about linking into all these. And if you can't, then it limits what you're able to do with Medicaid, Medicare, insurance companies. So there needs to be some thought about that. What else? Again, I think this greater collaboration, I think, can provide many benefits both for medical illnesses and serious mental illnesses. It's just something that we've got to get used to and work harder at. Historically, I think that we haven't done a good job with the communication because of the concerns about secrecy and privacy and discrimination. Some of, with HIPAA laws, there is a greater ability to communicate, but I think Connecticut actually has stricter laws that impair some of that. But it's something that we've got to work on, I think, to be able to facilitate this. Again, the idea with electronic medical records was that this would allow incredible communication. Unfortunately, the systems don't communicate with each other. So, you end up, if you get records, you can't just email it over. You have to print out the whole thing, and then you mail it to the other facilities, so it's really not working out as they imagined. I think psychiatrists are eager to work with new systems, that they're very interested in participating in collaborative care, to working with Medicaid and Medicare. There are some concerns about rates of reimbursement, I think, with some of that, which probably every medical field has. But people are really interested and want to look at what will provide better care. That's what we, as we go through medical school and training, we're always trying to learn what provides the best care. How do we do that, and how do we help our patients to the best of our abilities? And that's what we focus on. Thanks.
Good morning. Excuse me, it's always very humbling to get up after hearing from people who are on the front lines and actually dealing with the individuals, because my part of the program always comes down to talking about paying for it and finding the funds or not finding the funds. One of the things I do want to say that we've been trying for the last 4 years in the department to do is make sure that we are at the table in all of these conversations about the provision of care and the payment of care. Historically, that hadn't happened, and so there was a lot of schisms. There was a lot of bad feeling, and in fact, in some of the work that we've been doing over the last couple years, there's been such a buildup of frustration from the providers that we actually had to work our way through that before we could start working within the context of the mental health parity laws. So we recognize that, and I think there's still some of that out there, and I'm just here to say that the department is going out of its way to make sure that we convene frequently all the carriers, along with the providers, along with the advocates and so forth, to see what we can do to narrow this down. One of the biggest things that's happening out there is a number of agencies are getting together along with the Office of the Governor to see if we can narrow down the differences between what commercial insurance pays for and what the social programs pay for, because that's a real issue as well. And we don't want to see families doing some of the torturous things they do to get onto the public programs when there's no need for that. So we work with the carriers as well on that. Let me start with a couple of just laying out what the department does, sort of the funding sides of that, and then talk about what's coming up in the future in terms of policy issues in terms of mental health. But the most encouraging thing I'd like to say is that I do think the state as a whole and all of its agencies and the payers in the hospitals are working together more and more, because so many things are changing, which I'll talk about towards the end. One of the things you need to know about is that the insurance department actually is an assessing agency, so it assesses the carriers for its budget. and that's about $30 million. Some of what we assess goes to other agencies. Some of it's for all the immunizations that are out there. Some of it's for a small program for DEMIS of about $500,000 and so forth. The rest of what we do goes into the general fund. So if we sometimes come up with at least $100 million of other fees, fines, and so forth, and that does go into the general fund. Another thing that's really important to understand is that the commercial insurance market actually represents two pieces. There is the commercial insurers where you actually buy a policy, and that represents about a third of the marketplace, and that's over which what the insurance department has purview. There's a second piece, it's about another million individuals that are insured by self-insurance. So a lot of municipalities, very large companies, the state of Connecticut, which means that the employer takes on the risk, and they are actually regulated by the Department of Labor. So that's an interesting challenge when you hear about somebody's insurance company, because we really need to go further and find out, in fact, what type of structure they're in their company. And that gets frustrating for us because we don't have reach into the self-employed or the self-funded plans. And then finally, we do not have oversight, as these are federal programs for Medicaid and Medicare. However, all these issues that we're talking about cover everybody, all of the issues in terms of mental health and behavioral health. One of the things that we also need to make sure is clear is that, and I will talk about the don'ts and then we'll get to the things we can do. We don't have any expertise in terms of medical protocol. We don't have any regulatory authority over it or any in-house medical or psychiatric expertise, which is why it is so important for us to start working with the other agencies to be sensitized to the things, because up until now, we would just read codes, read diagnostic codes and so forth and work through that. And I think we need to have been brought to a real reality of what it is we're dealing with. So it's important to understand that the market actually is divided into thirds, and we have an oversight over a third of that, but that doesn't mean that we are not a voice at the table overall, because sometimes what we do can signal the other parts of this. We are in a state that I'm very proud to say, long before the mental health parity laws were formalized federally, as far back as the year 2000, we made sure that any policies providing major medical must provide mental health benefits. They can also not, at that time, they were not allowed to provide or impose any greater financial burden on a mental health treatment program. How that was instituted, there were a lot of issues with that. There's still things going out there, but at least by law, we were protected long before the Mental Health Parity Acts and then the most final regulatory clarity that came in 2014. In 2008, of course, you all know that the Mental Health Parity and Addiction Act came into place. The very obvious things were clear, the quantitative measures, but the non-quantitative measures were still unclear and gave people, unfortunately, a lot of wiggle room around. And so Pat and I spent some time trying to push our own delegation to clarify that, and in fact, in 2014, that did happen. We do now have clarity there, but that only went into effect in July of last year. So while we've been talking about it forever, the actual regulatory tools to use were not clarified until only several months ago. And then, of course, the Affordable Care Act, which, of course, does require that all these plans cover behavioral health and mental health. But that was, for us, not as big of a leap, and it's why you didn't see some of our rates going up as fast as others, simply because that was already embedded into our programs. One of the things that we can do is help people with grievances. And grievances are not just if you weren't covered by something and you thought you should have been. It's also if you are a provider and you weren't reimbursed for something. So one of the things that happened to us early on was we heard from one of the mental health societies, provider societies, telling us that due to new coding and so forth, they weren't getting reimbursed. And that was horrifying to us to see. We went in, we did a market conduct exam immediately on the particular carrier, and we found that in fact there were 812 providers impacted with almost 39,000 claims, and this was $500,000 over a matter of just a couple of months. So we quickly got that addressed, and everybody was made whole. And the carrier was not, I mean, when you move to a lot of these changes in coding and all of that, sometimes it's error and sometimes, we're not sure. So we are now keeping an eye on all companies. We do a lot of what are called desk exams. We call the companies frequently, and we are now what we do is we do a report card every year. A good chunk of that has to deal with behavioral health claims, and we break that down very specifically, not just generally behavioral health, but we'll look at residential, we'll look at for children, adolescents. It gets deeper and deeper, and we keep adding to that, and we publish this, and we publish it by company. So that way we can see where the trends are and if somebody's aberrant in terms of denials and so forth. And we use that data to go in and talk to the companies immediately. Mind you, it's a year in arrears, so we will not publish till May, the report for the prior year. So that's only one tool. We also need to hear from anybody out there, and all of you in this audience, we need to know if things like this are happening. You're not getting the right reimbursement, claims are being dismissed, all that type of stuff. That's what we're here for. And we need to, but we need your voices to come tell us how we can affect that. There have been a number of things that have changed as well. There are now new medical criteria for evaluating behavioral health requests, and I think those are still being refined, but they're out there and they're helpful. There's a requirement for a number of certifications for clinical reviewers. There's now a shorter 24-hour turnaround period for reviewing an urgent behavioral health care request. Obviously, someone can go to the emergency room, but prior to this, it was 72 hours. It's now been moved to 24 hours, so that denial, there are just too many things that happened, too many tragic stories that needed to change. We now have put in place for every carrier out there a mandatory annual market conduct survey for each carrier that needs to assert to us that it is compliant with the mental health parity laws. But we have all the work papers behind that. They can't just say it. We have a whole list of questions and data that we require. And their attestations are now published on our website. They're public, and anyone can see what's out there. And I think this really kind of brought the carriers to attention to say this is something that this department is very publicly focused on, and we will continue to be. And the only way we could really focus as closely as we have been is because we've had the benefit of people like Pat and other agencies who've kept us honest and said, you're not understanding this, this is what you need to do. And that's been very helpful, and it's really turned the department's focus around. And it's not only that, it's also money. I mean, this is a very large percentage of the care that's provided out there. And as we continue to say now to all of the carriers, if you start paying for some of these things now, it's going to save you tons of money. They know that. I think many of them are providing many more forms of care than that is clear out in the marketplace. So we are also working with them to do better in terms of making clear the services that are out there and the things that they are paying for. So for example, there was a myth that if you went to your pediatrician and the pediatrician also gave a mental health screening that on the same day, or if you were a provider and you wanted to give psychiatric medical advice or prescription and then also therapy on the same day, those would not be paid. That is untrue. And they should be paid, and if you tell us and let us know that that is not happening, we need to know that because those should be covered and paid on the same day and can be billed for. Similarly, if you do both screenings at a pediatric visit, they should be paid for on the same day as well. Double payment. But I think that's one of the worries we had, is that when you're going fee for service and somebody's saying, I just need to keep moving people through my office, that's a real problem, particularly if they're saying, I can't get paid for this. Well, you can, and we need to know if that's not happening. The other things that are happening out there this past year is there are laws that prevent the limitations. It was an option for the treatment of kids along the autism spectrum. There were dollar limits and they were age-based and so forth. This was brought to our attention by some of our legislators as well as some very, very thoughtful people from Autism Speaks when we looked at this law and we saw that in fact we were giving an option. It made me extremely uncomfortable. So what we did was go and call each of the carriers. And I will say, for those couple of carriers who were still enforcing the limitation, all it took was our conversation, and all the limits were lifted last year immediately and into the future. So there are lots of ways to operate that don't have to necessarily be legislative. They don't have to be hearings. Sometimes we have developed these relationships now where we can just call the CEOs and their medical directors and say, this just isn't right. And one of the things I did say was that we were going to publish a list saying who had limits and who didn't, and do you want to be on the list? And so we never had to publish that list. But it's sometimes the way that things can operate, and I think it was quite appropriate. Last year, we recovered about $4 million on behalf of consumers, and this was just people who called us and said, something's wrong here, we're not getting reimbursed, we're not getting paid claims, and so forth. So that's just something I want you to be aware of. There's an entire Consumer Affairs division that does that, and also, as I say, that informs trends that we need to be on top of. But this is what we have done. I think it's much more important to talk about the bigger issues that support everything you've heard here today. While we create things, you'll see outside, it left copies of our mental health toolkit, which is for families who don't understand how to navigate the reimbursement path, that you can take that and half of it's for you, half of it's to take to a provider. This doesn't work in an emergency situation, but it does if you're contemplating care, you don't know how to navigate, you're nervous about it. It's in very plain, simple terms to use or take with you. And the one message we say constantly is, don't go doing this without taking your provider with you. The provider will help you also navigate through the reimbursement spectrum. But there's a lot of information in there telling people that they need to find out if their benefits, what is covered in and out of network and so forth, and whether the facilities they perhaps want their children or their family members to attend are in network. If not, how can we help you, and on and on. And then, of course, you can just call us and talk about that. We have created a mental health parity page on our website that lists all the tools we have and all the things we can do for you. But again, we need to be out more like this because not everybody's just going to go, scrolling around on websites, but the tools are there. I think more interestingly is the issue that keeps coming up is the transfer of risk. As we're seeing this, we're very supportive of it, the move from fee-for-service to risk, but what we are seeing is an awful lot of the typical and traditional payers are moving now to getting out of the risk market, moving into services, moving into other countries, a lot of capital is being redeployed there to take on the risk. The margins required for commercially, regulated businesses are fairly narrow based on the medical loss ratios and so forth. So this is being moved on to the hospitals and the providers. My concern is that you're already dealing with professionals who are taking on medical and care risk and now saying, okay, now here's some financial risk for you to take as well. You didn't go to business school, you don't have this in place. It's enormous pressure on this system. And I think there's a gap there that we need to address and find ways to work together more and more on this, because if we are moving towards these groups becoming the insurers or payers, number one, we have some state laws in place that don't permit that to happen, so we need to look at those and see if Connecticut is out of sync or if there are ways to address that or whether we should leave them in place. So that's a conversation that needs to happen. We also need to make sure that everybody's got the skill sets to understand accepting the financial risk. And we also need to have a provision for people to fail, because not everybody's going to succeed in this transition, and we need to we have enough issues with workforce in the state, even though we're better off than many others, that we need to allow people to continue to practice medicine and not constantly be looking over their backs about their risk transfer to them as well. And so this is where we're seeing a lot of the hospitals doing wonderful work, stepping in and trying to provide these models. But still, there needs to be money for failure so that you don't lose your medical license because you're not managing money. same way. And so this is something that there's a lot of attention being paid to. But I think from a regulatory point of view, it gets my attention because we have to look at what is it we're going to be regulating, what organizations are we going to be regulating, how can we be most helpful, let's look at the laws in place and so forth. So I will stop there because I think this takes us to, I hate to be the grubby person talking about money all the time, when in fact the most important things are, the primary provision of care. So thank you.
Good morning. Thank you for inviting me, Amy, and thank you all for coming. I'm going to talk about the law, the Affordable Care Act, and behavioral health in, 5 minutes? That's going to be a little like drinking from a fire hose. But, so we'll just hit a couple of high points. There are very wide range of laws that affect behavioral health, but what we're going to focus on for a couple of minutes is the Affordable Care Act on the one hand and federal law and the state laws that we have in place here in Connecticut. The first thing, and Melissa, Commissioner Dowling, I spent 30 years with the AG's office, so I worked closely with Ann, Melissa, and Pat for a number of years. She mentioned the difference between self-funded and insurance. That is, from a legal standpoint, that's a crucial distinction because self-funded is governed under ERISA, which most of them are, is governed by federal law. As Ann Melissa said, if you go to her with the most egregious, outrageous denial of coverage, but it's a self-funded ERISA plan, the state law and the state regulators do not have jurisdiction over that. So there are two dichotomies. People could have the same illness, go to the same doctor, receive the same treatment, and when it comes time, one pays a $15 copay and the other one pays $1,500 because it's not a covered benefit. So that's an important thing to keep in mind. So let's just pick a couple of the laws. Parity, we've heard a lot about. When I was in the, as I said, I spent 30 years in the AG's office doing healthcare fraud, healthcare advocacy. And we did, in the late 90s and early 2000s, we did two major investigations on healthcare parity, behavioral health parity. Horrendous situations where behavioral health was being denied. Kids with a rope around their neck couldn't get inpatient authorized. I mean, so we're talking about real trauma to the patients, the families, and the system, really. So as Ann Melissa said, we in Connecticut were way ahead of the curve on parity. We've had those laws in place, since 2000, at least, and in some ways even before that. But the federal government, but again, keep in mind, if it's an ERISA plan, that's not covered under those state statutes. So the federal government came along in 2008 and they put in place their own federal parity because it's a federal law. Now the federal ERISA self-funded plans were covered. But even there, it was covered only to the extent that it was a large group self-funded plan. So if it was an individual or a small group, you weren't covered by the 2008 Act. So now, fast forward to the Affordable Care Act, and we have a situation where the Affordable Care Act did two things. First of all, it extended essential health benefits to individual and small group plans. Now, the other thing about ERISA plans is that there's no requirement in ERISA itself for what has to be covered and what doesn't have to be covered. The example I always use is, well, the plan, the employer could decide, well, I'm going to cover carpal tunnel, but only for the left hand. Well, but most people are right. Yeah, that's right. Most people are right-handed. That's why I'm covering only the left hand. And, you know, and there's nothing anybody could do about that. So what the Affordable Care Act did, at least as to individual and small group plans, is to require that 10 essential health benefits be covered. And one of those essential health benefits is behavioral health. So that dramatically expanded the coverage of behavioral health. The second thing it did was to add or extend the parity requirements over to those essential health benefits. So if you're in a group plan, then you need to comply if it's small, and you already did if it was large, if you offer mental health benefits in that large group plan. There's still no requirement, no legal requirement, that a large group offer behavioral health coverage. But as a practical matter, I believe, and folks on the panel can tell me probably better, but as a practical matter, the coverage generally does come because employers, large employers, recognize that it's really in their interest to provide complete coverage, and so I'm told they do so. So that's one of the two big areas. The other area that I just want to touch on in the interest of time, which is slipping away, but utilization review, and that is kind of the successor. I mean, parity is an issue, but at least you know, many of the companies, having been on the watch list or knowing that they're being watched, don't have the blanket, the quantitative or the non-quantitative treatment limitations. So they won't say, as the companies that we investigated years ago said, you know, well, you can have 2 outpatient visits for mental health and, you know, 36 for physical therapy or something along those lines. It's not always that clear cut anymore. But the problems become when, oh yeah, we cover that. Oh, but your case, no, that's really not medically necessary. And so now you get into a battle of the experts as to what's medically necessary and what's not. And the other big area, again, Connecticut was way ahead of the curve on this with internal appeals and external appeals. But again, that only covered the state insurance, those that the insurance department had jurisdiction over. On the federal side, the Affordable Care Act made a very sweeping and comprehensive list of utilization review requirements and internal and external appeal requirements. So that's another big thing. Just to echo what Ann Melissa had talked about, there are really a number of excellent state organizations that can help. My own department at the Attorney General's office, we did healthcare advocacy and would help people and providers who were not getting paid or were not getting covered. The Office of Healthcare Advocate also provides assistance to people, and the insurance department itself, as Ann Melissa said, they do an excellent job as well. So there are resources that can help you if you're either not getting coverage or you're not getting paid. With that, I'll wrap up, and I thank you very much.
Okay, that's better, I think. So we have not much time, and so I want to turn this over to you. You've been very patiently sitting, I think, hearing from some real experts, hopefully getting some knowledge you didn't have before, and now we need some questions. Oh, God, you've all been lulled, I think.
Oh.
Way back there, and then Jeff.
Good morning. Thank you very much for the information, your comments. I'm Lynn Ostrowski. I work at Health New England, which is based in Massachusetts. And so what we've seen in Massachusetts, you talked a lot about mergers and acquisitions, and what we've seen is those actually drive up the cost of care and do not impact the quality of the overall care. So how will you regulate those and look at those and review those, and what requirements will you put on them? We have the Health Policy Council in Massachusetts, and as you know, they've just denied the partners, and now that's going to court. So I think that's a big issue for the state of Connecticut as well.
So is that your question, what they're putting in place
That,
in terms
and
of
as well
monitoring?
as another comment of, throughout the entire discussion, when we talk about the onset of mental health, we talk about it happening in adolescence, and there has been no discussion of the school department and school policies around when these kids get in trouble, they get suspended. And when they get suspended, they get in more trouble and they get arrested, and then they get into the juvenile system. And there's no coordination between the educational system, the juvenile justice system, and the mental health system.
So you're asking two questions of the panel here in Connecticut?
Yes.
One, the first question about mergers and acquisitions and oversight, and the second about coordination for children. Who wants to take that on? Pat?
I can talk about the mergers and acquisitions and the way we handle them for behavioral health in Connecticut. So we don't have any regulatory authority around mergers and acquisitions. We support them. We think that there are some economies that can be gained by them, and we've seen that happen with some of the mergers. And so our stance as the department is simply, if you're going to merge or you're going to change your structure, you have to work with us around contracts. And so if we have two entities that merge entirely, you don't necessarily get to keep your contract because of the merger, right? So we have to issue new contracts. I will say that we have never not been able to work that out. It has never been a problem for us. So it may be just a little different than in Massachusetts.
Somebody want to take? Brian, I think the children and adolescents and all the departments working together.
Yeah, I think that has been a concern over years. I think that we're trying to do a better job of that now in Connecticut, rather than go with this zero tolerance policy, which just involves more kids in the juvenile justice system, to really try more early intervention. There are some school-based mental health clinics. Also, there are what's called emergency mobile psychiatric services that people in the community and schools can access if a child is out of control, to try to calm things down, maybe see them over a brief period of time, and then if they need to be linked to community-based services, to do that, to really try to get them the help that they need rather than to punish them.
Great.
So that's a very important point.
Thank you. Next question, Jeff.
Thank you. This is great panel, and I have a quick comment, quick comment question for Commissioner Dowling. I'm thrilled that the Department of Insurance is getting engaged in these issues, and your plans seem really great. Quick comment is about the coding. I think we do still have a big problem in Connecticut with the behavioral services being able to be provided in the primary care setting on the same day as another service, so I would encourage you to keep digging in that area. I think the insurers are philosophically aligned to allow that, but their systems are not necessarily equipped to pay two E&M codes on the same day, and they don't have modifiers in place often that distinguish the behavioral services. So that's kind of technical, but it's critical to us being able to provide integrated care in the future in the primary care setting. My question is really about your plans for looking at parity and being able to enforce it, and what you might be doing in collaboration with the Office of Healthcare Access, which also tracks grievances and consumer grievances, and on their website you can always see that the largest number of complaints to the OHA is in the behavioral health area. I was just wondering if you could just talk maybe one more minute about what you're going to do to actually enforce these parity rules? Thank you.
Thank you for your comment. First of all, I'd hope to talk with you soon, because if you can assist us with whatever work and research we need to do with the coding, let us know, because I thought we had that, and if it's still not under control and practically not happening, we probably need some guidance from you as to how to look through that, so we will. We actually were asked by the legislature to provide a report that talked about how we were going to comply and enforce compliance with mental health parity, and that was provided last year. It's a very long presentation. It was what caused us to create a whole new package on the grievance system, sort of a guide to how do you go through that process. It created our toolkit for consumers. It caused us to create that certification that companies now need to make every single year to us. And we are adding more things to our report card. And we are getting that input from providers and from the other agencies asking us to monitor the following. So we can only work on empirical data. We cannot go in on anything that is just, it doesn't feel right. We need data. So any case that we have, obviously we're not a legal system, but and so that's why we're working with outside law firms, with the AG's office, with Pat, to identify it. But that is something that is taking a very large portion of our resources to make sure that we don't let anything slip through the cracks. Because you can be right later when somebody's family trauma is over and you can't help them with anything but money, and that's not enough. So we need to hear from all of you, immediately. On things you see, and we can pursue.
Great.
Is the information that you're finding available on, like, the website, or?
In terms of these report cards and so forth? Oh, it is, and we also send out, in physical form, but yeah, it's all on there. In that, if you go into the department's website, there is that mental health parity section. You click on it, and all this data is underneath. Okay. But if there's anything specific you need, call me.
It's an interesting question. Before we get to the next question, we also are always looking for parity violations, and they're being reported. The biggest problem is people not reporting them, because you can't take action unless you know. We have a question there in the center of the room.
Yes, thank you. My name is Frank Fortunati. I'm a rehabilitation psychiatry at Yale Hospital, and also private practice, child, adolescent, forensic psychiatrist. And Commissioner Reamer, I really like what you had to say about changing the dialogue away from stigma to discrimination. And in light of this conversation about parity, it also calls to mind that there is some fixed discrimination in our state laws, and a lot of it is a misunderstanding of the differences between confidentiality of medical records and a privilege of privileged information, a privileged use of medical records. If we want to be more collaborative, I think we need to change the way we discriminate against the sharing of mental health information among providers. It makes it very difficult. And so many times, I've seen it many times, people just leave the Department of Corrections and don't get their medications filled, and they're in a hospital a week later or arrested again, and try and get information from the Yukon health system, mental health folks, without signing every single part of that form correctly. It's impossible. And so many people don't do that. So I'm wondering if there's any look at changing the laws to make sharing of mental health information among mental health providers
Pat,
a bit easier.
you want to take that?
Let me just say quickly that one of the things we're really focusing on in this year and in this session is increasing collaboration between the Department of Corrections and DEMIS. We have a great relationship. We really want to increase it so that when people come out, they're either already engaged in treatment or on methadone or some of the things that we think will help. I think, frankly, that we hide behind HIPAA laws, and I know that's going to make all the lawyers in the room uncomfortable.
It is true, though.
And I know if Henry Salton was here from the AG's office,
Things are breaking up here. Huh?
yes, I know. But I think there are a lot of ways to talk about care within those laws. There's a continuity of care issue that's stated, so you can share information if it's about continuity of care. if it's about treatment planning. I mean, I really do say to our clinicians all the time who say to the parent, I can't say anything to you. Now, we treat all adults, oops. So, you know, that's what we have said for years. We have to stop saying that.
That's
There
right.
are a lot of ways to communicate. And one of the reasons I feel that we haven't had as much access at the national level is because that's what our other partners, our medical partners, are telling us. You guys won't share information, you
Right.
hide behind your HIPAA laws.
Totally true.
And yet there are provisions in the
That's right.
laws. And so I think we have to re-educate ourselves in Connecticut.
Absolutely.
Yeah,
I
that-
couldn't agree more. And actually, at our own National Council conference, we have held workshops called Hiding Behind HIPAA. I think it's an excuse sometimes for laziness, and I think an industry was built around the HIPAA laws, making them more complex and complicated than they need to be.